This is special to me. Okay, we're going to start off with the skin. Before we get to the skin, though, as in anatomy, you need to be aware of the different sections and planes of the body, because that's how I'm going to be referring to them as we go along, and that's how you refer to them in medicine. If you look on your left-hand side there at the bottom, the three general planes are coronal, which is this direction, sagittal, which is this direction, and horizontal or transverse, which is this direction. With computerized tomography, CT scans, and MRIs, because they are computer-based imaging modalities, you ordinarily take slices in through the transverse plane through the body. But because they're on a computer, you can sit there and turn the images. You can combine the images to go from a transverse plane to a sagittal plane or coronal plane. It's amazing what you can do to manipulate those images. So these images, these planes are very important when you're talking about diagnostics. If the sagittal slice is right in the middle, it's mid-sagittal. If it's off the midline in either direction, it's parasagittal. Now when you get to the top left there are different directions. This is the anterior surface of the body, the ventral surface. This is going to be the posterior surface or the dorsal surface. So I can tell you right now, in that illustration up there, when you're talking about relationship of one structure to the next, you can see that this guy's nipple is anterior to his shoulder, or his shoulder is dorsal to his nipple. So in conversation, the relevance, the positioning here is important when you're trying to describe something. If it's towards your head, it's cephalad or superior. If it's towards your feet, it's caudal or inferior. Over here on the right-hand side, this gentleman is in what's called the anatomical position. So to avoid confusion, if something is described in relation to the other, it's in this position here, with the palms towards you. And actually it's not quite right, because the anatomical position, the penis is erect. So when you're talking about the dorsal, you're describing a lesion on the dorsal surface of the penis. In this picture, you would think it was the underside, when in fact the anatomical position, the correct anatomical position, is with an erect penis, so the dorsum of the penis is on the top. So when you talk about the deep dorsal artery, dorsal vein, that type of stuff, it's on the top, not as it's illustrated here. Okay? If something is more towards the midline, it's considered proximal to a structure that's more away from the midline, which would be distal. Your digits are distal to your elbow. Your elbow is proximal to your digits. This is the palmar surface of your hands. This would be the dorsal surface of your hands. When you're looking at the feet, though, it's a little different, because back when you were a little embryo, you developed like this. You were like a four-legged animal. But because you're bipedal, what happens is your back legs, they came up and rotated out like that. So the dorsum of the foot is there. But understand, if you were an embryo, it used to be just like your hand, like that. The dorsum of the foot is like the dorsum of your hand. Think of yourself as a flat pancake, right? This surface of the foot is the plantar surface of the foot, plantar. So if I'm going to flex my ankle, I either dorsiflex it or plantar flex it, okay? moving your limbs away from the midline is abduction, abduction, A-B-D-U-C-T-I-O-N. Bringing them towards the midline is adduction. And there are certain circumstances where that falls apart just a little bit. If you're talking about your digits here on your hand, abduction and adduction is not in relation to the midline of your body, but to your middle finger. That's abduction. That's adduction of your fingers. It's of the digits themselves, not the body. Okay? Also another, when you get to the upper extremity, this is the radial surface, which is also the lateral surface, versus the ulnar side of your upper extremity, which is also the medial surface. So if I do this, that's medial deviation or ulnar deviation of the wrist versus radial or lateral deviation in this direction. In the lower extremities, you can take your lower extremities and rotate them outward, which is lateral rotation or medial rotation. And one special motion is to be able to do this, to take your shoulder and go all the way around. That is circumduction. Circumduction. Now when you're looking at joints of the extremities, you can also consider these for the spine. There's extension and flexion. So flexion typically brings the two surfaces together. Like I'm going to flex my elbow. I'm bringing these two surfaces together. Extend my elbow, you bring them apart. Flex your knee, extend your knee. In the example of the shoulder here, you can flex your shoulder this way. You're not bringing anything together. You flex your shoulder that way, you extend it that way. You abduct it, you adduct it, you circumduct it, or circumscribe it. Okay? So as we go through the different limbs, I'll hit you up on some of the different movements. You know, one of the really weird ones is the thumb. Because the thumb, you have another movement other than flexion, extension, abduction, adduction, and that is opposition, which separates you from lower animals and graduates of Alabama. Okay? Any questions about any of that? All right. I mean, that's, you know, you're going to get used to, as we go along over the next few days, using these terms without, you know, they'll be so ingrained. By the time you get to the clinic, they'll be part of your nomenclature. Now the skin. You know it's the largest organ, you know it's the heaviest organ. Funny thing about it is if you take the kidneys, you got two kidneys here, kidneys make up about, well, less than 1% of your body's weight or mass. If you take the brain, that makes up just a couple of percent of your body's mass. The kidneys themselves, they get 25% of your cardiac output. The brain gets another 25% of your cardiac output. The gut gets 25%. And then the largest organ of your body, in addition to all of the muscles of your body, gets the remaining 25%. So despite the skin, if you stretched it out, it'd be the size of a full sheet. It's that big, 15, 20 square feet. That's smaller than a queen size, bigger than a twin, full. That's how big your skin is, if it's all stretched out in meters squared, so to speak. Gets less than, well, it just gets a fraction of your cardiac output. And that's pretty amazing. Of course, the functions of the skin, not only to keep you from drying out, they certainly have a thermoregulatory role. They have, in some instances, a waste elimination role, especially if you have severe renal failure. Okay. Edgar Sue, you from Men in Black, right? Men in Black. That guy, I don't know who that is. Yeah, it's not good. Okay, so if you look at the skin, it has several different layers. The outermost layer is the epidermis. The epidermis varies according to its function. In the forearm, where there's little friction, it's only a millimeter or so thick. When you get to somebody that works in manual labor, calluses build up on the different surfaces. It can be several millimeters thick. The epidermis sits on a basement membrane that's secreted by one of the two cell types called the keratinocytes. The keratinocytes are the predominant cell type that rests on that basement membrane. And what they do is they divide, and the daughter cells migrate north. As they start migrating north, they start producing a protein called keratin, so that after a couple of weeks, they're about halfway up through here, they're almost nothing more than just a bag of keratin. The cells become pycnotic, P-Y-K-N-O-T-I-C, pycnotic. That means that the reproductive machinery, like the nucleus and things, are condensing down so that it's no longer able to transcribe and translate proteins. It's just nothing more than a bag of keratin, which is a protein. The cell actually dies here in about the lucidum layer, and then you get the outer corneal layer, or keratinized layer, and that process from the basement membrane to the top accounts for, takes about 28 days. On average, about 28 days in everybody. There's another cell type on that basement membrane. Those are melanocytes. You can see here they're stained with an antibody to some melanin-producing protein. What happens with the melanocytes is they make melanin and they transfer it to the keratinocytes, who take it to the surface. The melanocytes normally never leave the basement membrane, and they don't divide and send their daughter cells north. They stay on the basement membrane, transferring melanin. Now, the rate of transfer is genetically determined, generally. It can be accelerated if you're out in the sun more, and that's why you turn darker with more sun exposure. Interestingly, if you look at you, the distribution, if I do a darker skinned person, can you hold out your hand the other way? The distribution of melanocytes differs between regions of the body, and it's more evident in darker skinned individuals. But it's the same if you look at a square centimeter of skin between you and you. You're red hair, is that red hair? Red hair? Okay, there you go. The number of melanocytes is the same. What differs is the rate of transferal and the distribution of melanocytes in the body. Okay? So as this one bullet point down here says, it really doesn't make a difference by gender or race. It's just the rate of transfer, which predominantly genetically programmed. Right? The epithelium, the epidermis is avascular. There are no blood vessels in the epidermis. If you cut yourself and you're bleeding, you've gone through the epidermis. You've gone through the basement membrane. It does, however, contain free nerve endings that are that sense pain and temperature. Not touch, but pain and temperature. That's good because you would want the most, you would want the sensation of pain, particularly as closest to the surface as you can, as you stick your hand on that hot stove, that sort of thing. The other thing that you need to pay attention to, this is keratinized skin. If you look inside the mouth, inside the nose, inside the vagina, it's the same layout. However, those cells do not become keratinocytes. I don't know if that's exactly a word, but they remain moist, so they're mucous membranes, not keratin. It's amazing how much this sloughs off normally. You know, I'm amazed at mattress commercials. You know, the Tempur-Pedic mattress, you know, lasts 100 years, guaranteed for life, that sort of thing. Well, the recommendation from the mattress manufacturers of America is that you should change your mattress every 10 years. Why do you change your mattress? Because it wears out, you know, it wears out. There's a dichotomy there. These people are saying, buy one, it lasts forever. These people are saying to change it every 10 years. I don't know, it's something that really bothers me. The thing that really bothers me, though, is that the weight of a mattress, when you put it in your house, if you were to weigh it 10 years later, it's doubled in weight because of the creatures that live in it, eating the tremendous amount of keratinized skin that normally sloughs off of you. So, you're kind of gross. Here's a superficial skin infection that only involves the epithelium. It's called ringworm, or tinea corporis is the name of the medical name of the fungus. It's a very common fungus, loves moist environments. It takes a good amount of contact to transfer this from one to the next. We see it a lot in elementary school kids that are rubbing on each other all the time. We see it a lot in wrestlers. One wrestler gets it, they'll all get it. It's just, it's very common. And you get it in one place, and then as it grows, as it multiplies and expands, you see this is the bug right here. It's a hyphenated type organism. As it grows, it has an active border. So the expanding ring, and they're usually always symmetrical, the expanding ring is usually raised. It's scaly with central clearing. So when you're on Jeopardy, if they say, you know, raised active borders with central clearing, the answer is going to be ringworm. Okay? Now the way you treat this stuff is very easy to treat. You can treat it topically with ketoconazole, 2%. You apply it a couple of times a day, but you have to apply it for at least a month. Why do you have to apply it for at least a month? Because this stuff is going to infect all the way down to your basement membrane, and it takes a month to grow those infected keratinocytes all the way to the surface. So that's why you treat it for a month. Okay? And tell people when you prescribe it, you're not going to see much of a difference over the next 2 weeks, but then it should start fading pretty quickly after that. All right. One other thing about the interesting thing about the epidermis are the fingerprints. Now, the fingerprints that you see on the outside are really the result of dermal papillae that stick up from the inside. You see the dermal papillae right there? Your fingerprints are determined by two different things. It says determined in utero right here. That's true, but only half so. Well, sort of. They're genetically determined. There are 3 general broad categories of fingerprints: whorls, arches, and something else. That's genetically determined. What is not genetically determined, though, is the specific pattern of the whorl. That is determined in utero because the embryo and the fetus is in there touching things and touching the walls of the uterus and everything else. And they develop their fingerprints because of that. And it's because of that, when you take identical twins who have everything exactly the same, except fingerprints, okay? They have the same whorl, but they don't have the same print. And that's just because of the contact that's made in the uterus. Now, the purpose of the fingerprint is believed to be and help in gripping, to increase friction instead of a flat surface. If you look at, so in your fingers, you see nice ridges. But in other parts of your body, if you look at the formation of these dermal papillae, they're different. Where it says right there, in other places ridges are polygonal or lozenge shape. If you look on the back of your hand here, they look more elliptical. They look more like that. Okay? So different parts of your body, they look a little different. If you really want to see some weird stuff, go look on your neighbor. That's one place you can't look. You can't look on your elbow. You can't look at your own elbow. But you can look at your neighbor's elbow and see that it's ugly. Okay? Yes, ma'am.
Can you really show off your fingerprint?
Huh?
Like how mastermind criminals, they'll won't leave fingerprints behind because they stage them down? Is that a thing?
Yes, but let me give you a bit of advice. My daughter is interested in forensics, so she knows useless material like this. If you were to sand off or grind off or burn off your fingerprints, that makes you absolutely unique. So it's actually easier to catch you if you don't have fingerprints. Because you know how many people don't have fingerprints? 4 in the entire world. The 4 dumbasses that try to So it's actually, you can do it. But it's not for the reason you do it. For the reason, so anyway. Okay.
Do they return?
No,
Yes.
no. If you scar them down with burning and stuff like that, they're not going to return. If you just sand off the superficial surface, they will return because remember it's the dermal papillae that's determining things. You got a question? No. Okay, here's some other superficial things. Basal cell carcinoma is a tumor of the cells along the basal layer of the keratinocytes. Essentially, they become they're mutations, they're mutated cells. They no longer take on the characteristics of a normal keratinocyte. What they do here, you can see the basement membrane. You see they're still on the basement membrane, but they start growing. They can become ulcerative, like you see here. Sometimes they're more pearly in appearance. Here's one that's quite a bit more extensive. These things, if they're not treated, they will grow. They don't have malignant potential. They just grow locally. This is a patient I actually saw right here. Came from southeastern Oklahoma. Showed up in my clinic. His basal cell was so extensive, he had no ear. It had eaten off his ear. And if you get close to this thing and blow it up, there's his external auditory meatus right there. He had clear fluid draining out it. That was cerebrospinal fluid. That black thing right there is the backside of his parotid gland. And when I did the CT on him, this basal cell had invaded around the carotid artery and into the sternocleidomastoid, into the muscles of the posterior spine. And I'm sure one sneeze and he would just rupture. So he never followed up. So it was really strange trying to get this guy. So I see him in clinic. I go, wow, you don't have an ear. I called the referral person. So I need to get this guy CT now. And it was a nurse out of New York. And she said, well, how big is the lesion? I said, well, it's not really a matter of big. It's about 4 centimeters by 3 centimeters, but it involves his entire ear. It's gone. Well, okay, if it's on his ear, how big is it on his ear? Oh, you don't understand. He had no ear. I mean, it took me forever to get across to that woman to approve this. Well, we can't approve it until you tell me how big it is. It's the size. Oh, it was just round and round and round and round. Okay. The other cell type involved in superficial cells, a squamous cell carcinoma. Basal cells and squamous cells are sun-induced. You know, the more sun, the more likely you are to have these things. Squamous cells, though, they don't involve the basilar cells like you see in basal cells. These cells are higher up, like the granulosa layer. That's where these tumors develop. These do have malignant potential. If you don't get these treated, they can metastasize. So you see right here, and these usually produce an ulcerative type of lesion that's usually a telltale sign, a shallow ulcer, non-painful. You know, if you see these things, you know, don't mess around with them. Biopsy them or take them off. That's the way to go. Versus melanoma. Melanoma is obviously derived from mutated melanocytes. They are superficial to the basement membrane. That's how they start out, superficial to the basement membrane. If you identify them and excise them prior to them extending through the basement membrane, you got a 100% chance of survival, cure. It's only though when they invade through the basement membrane and enter the dermis and the subcutaneous tissue that it becomes not only malignant, but metastatic and deadly. And there are different characteristics between non-metastatic cell type of lesions and melanoma here. Multiple colors, irregular borders, larger size, fast growing, all of these things contribute to, oh no, this is something that's got to come out now. Okay? The way that these things are typically removed is through a process called Mohs surgery. And what Mohs surgery is, if this is the lesion, the dermatologist, and dermatologists are the only people that are credentialed to do Mohs surgery, they'll go out and make a wide and deep excision, and then they'll look at the borders here to make sure that they're clear. If they still contain suspicious cells, they'll go back in and make the excision bigger. And they keep going until they have clear borders. That way they know they got it all, and they'll close it from there. Okay? Any questions about any of that? Here's some other reasons to stay out of the sun. Seborrheic keratosis, old folks get this. I've got one on my back somewhere. My wife said it's on there, and it's ugly. You need to get it all cut off, you old goat. But it is a waxy appearing lesion that's raised. It's rough. It looks warty. It's actually an overgrowth of epithelium, and it looks stuck on. It looks like you could just take the edge of it and peel it up and peel it off. And actually you can, but you shouldn't do that. Now you can treat these by simply freezing them, or you can take a blade and just cut them out real easily. But seborrheic keratosis is quite common. These are not premalignant lesions. Actinic keratosis is a premalignant lesion. It's flatter. It's still waxy and scaly. And these are very common. These appear on the face, the neck, the arms, these kinds of things. Sun-exposed areas. It's very unusual to find one of these on an area that's not sun-exposed. Finally, the solar lentigos, or liver spots. These are the hyperpigmentation, increased pigmentation that you see on the back of people's hands. I've got a couple of them here. They're flat, they're macular. Macule means that it's flat. Okay, a lesion that's flat. So liver spots. Now the dermis, if we go beyond the basement membrane, we'll hit the dermis. The dermis is a very thin layer. It's the thickest part of the dermis is on the soles of your feet, and that's only a few millimeters. So if you're talking about the forearm and stuff, you're talking about less than a millimeter. It's very, very thin layer. Nonetheless, it's a very important layer because the predominant cell type in the dermis is the fibroblast. Fibroblast is a cell that secretes collagen and elastic fibers. Collagen fibers and elastic fibers. These two proteinaceous fibers, we'll go over the biochemical structure of these fibers later on and the diseases associated with them. But suffice it to say today, fibroblast in the dermis produce a lot of collagen and elastin. Now, collagen is what makes the skin tough. Elastic fibers give the skin its recoil. So if I pull my skin up like that and let it go, it recoils. That's called tenting. If I pull it up and let it go and it stays up, then there are one of three things going on. Either I'm a little infant, I'm an elderly geriatric person, or I'm severely dehydrated. One of those three things. Okay? Mine doesn't stay up, so I'm not an infant, I'm not a geriatric person yet, and I'm hydrated. Okay? Now, with elastic fibers, it says there increases to adulthood and then decreases significantly. When you do this to your great-grandma, when you go home this weekend, when you let it go, you'll see that the skin stays up. That's tenting, okay, positive tenting. I mentioned the collagen fibers with the strength. In the elderly, the collagen fibers tend to cross-link and they lose their strength. Also, in elderly people, they lose a lot of the fatty tissue, the connective tissue down here as they get older, which contributes to the thinning skin of the geriatric person. The dermis contains blood vessels. It contains lymphatic channels. It contains all manner of nerves. So when you think about sensations, there are a whole bunch of different types of sensations. I mentioned pain and temperature, but there's also touch. I can touch you and you don't have to look at it, and you can tell me exactly where I touched you. Those receptors are in your dermis and deeper. They're not in your epidermis. Okay? Also, being able to perceive where my limbs are in space without looking at them is a type of sensation that's called proprioception. Those sensory terminals are not in the dermis, but they're in joint capsules predominantly. So you know how contracted or flexed or extended a joint is. They're also in other structures, but joint capsules predominantly. Vibration is a sense. The ability to discriminate, am I touching you with 2 points or 1 point, and I'll illustrate this later, is also a sensation. And so there are lots of different senses that we're going to go over here in anatomy. But all of that is picked up in the dermis, with one exception being proprioception. Yes, sir?
Are you considering discrimination different from touch right there? Or are those the same?
Yes, yes. He asked, is discrimination different from touch? It is a type of touch, but it depends on, well, I'll illustrate it now. So, I need a, can we come in? Yeah. Oh, yeah. All right, so you see I have 2 points here. Okay, hold out your hand. Close your eyes. Now, if I look at the nerve fiber density and the ability to sense touch in his fingers, which is going to be very keen, right? On your fingertips and on your face. That's where this is most sensitive. I want you to tell me, am I touching you with 1 point
or 2, okay?
Just one.
Okay, that's good. Good. Close your eyes.
That's the four.
Still 1?
Yeah.
Okay, all right.
Now two.
Now 2. That's obviously 2?
Yeah.
All right, so you see how far these things are apart. They're a couple of millimeters apart? Okay, turn around. Can you hold this shirt up? Okay. All right. Am I touching you with 2 or 1?
One.
1. So I'm that far apart. He can't discriminate on his back. So that is 2 points versus, that's ability to discriminate 2 points is a type of sensation. But it also has to do with density, oh, thank you, sir. Density and the type of receptors that are there. Okay? If you look at I'll just give you a heads up. There are 2 sensory pathways that you spend a lot of time with. One sensory pathway carries pain and temperature. The other sensory pathway carries everything else. So regardless of what type of sensation it is, knowing that it's one of those 2 pathways, that's the bottom line important point. Pain and temperature goes one way, everything else goes another. Now, in elderly people, I mentioned the thin skin, the cross-linking, the loss of elasticity, produces a very, their skin tears easily. This is a warning in a nursing home right here. You can't just go to a person, an elderly person, and grab them, let me help you sit up. You can't do like this because you just rip their skin. It just tears. There are several problems with this. One of them is it's impossible to suture because their skin is so thin. One way to suture it, though, is if you've got a clean and deep enough tear, is to put what's called a steri-strip. It's like a Band-Aid. Put a Band-Aid, put a steri-strip on each side of the laceration and then suture through the Band-Aid. And that gives you more support. But you see right here, if you read this part right here, everything that contributes to the thinning skin of the geriatric person. You're going to be dealing with this a lot in the ER. And these things, they do not heal. Most of the time, they will, you can tap them back together, but because they're so thin and they're so poorly vascularized, you're going to lose that flap eventually. Okay, so we go to the deepest layer now. The deepest layer here is called, from an anatomical standpoint, the hypodermis. Nobody calls it the hypodermis, though. Clinically, it's the subcutaneous tissue, which is the first one, subcutaneous layer, subcutaneous tissue. Anatomists also like to refer to it as the superficial fascia, the superficial fascia, to distinguish it from the deep fascia. If you notice this part right here, which is over the this part of the cadaver, we're down to this clear, shiny tissue, that fascia there. That's the deep fascia, that's the outermost covering of the muscle. So the superficial fascia is superficial to the deep fascia. That's obvious. It attaches to the deep fascia, it attaches to the dermis. And it's what gives the skin the ability to slide on itself. If you take your scalp here, I mean, you can slide your scalp all over the place because of this relationship, okay? It can vary in thickness between, if you see some of those cadavers over there, they're sort of, some of them are sort of cachectic. They look emaciated, not, well, cancer is what kills some of them. So they're not, they weren't well, versus you go to the mall and you look at the number of diabetics walking around, the thickness of the subcutaneous layer can be anywhere from millimeters to actual feet. When you get a 400-pound person that you're doing surgery on in the abdomen, the superficial fascia is it's feet thick. It's pretty impressive.
And it expands because of the adipose that's being added to it, kind of thing? Like, is that why it gets bigger?
Well, the adipocytes, which is the cell type that you're going to see here, they're getting bigger. I'm not sure, I don't recall specifically if you can increase the number of adipocytes. You can increase the size, you can shrink them. But I'm not sure, I seem to recall that adipocyte numbers don't really change that much. It's just the size.
So they
Okay.
grow, they don't multiply.
Right, they don't multiply. You know, they're like muscle fibers, they're like nerve fibers, they don't multiply so much. Fibroblasts multiply like crazy. Keratinocytes do, and so, you know, as we go through the year, you're gonna find that cells do divide differently. You know, you replace your skin every 28 days, you replace the lining of your stomach every 24 hours. So it's quite variable. Now, the superficial fascia is, it contains everything, nerve endings, sweat glands, the vasculature, lymphatics. Does anybody not know what lymphatics are? Does anybody not? I don't mind telling you, but okay, all right, so we're good. Okay. All right. This is a type of skin disease you're going to see quite common. Probably 2 or 3 of you in here have it. It's psoriasis. What psoriasis is, you know, we talk about the keratinocytes taking 28 days. What's going on here is an acceleration of that 28 days. So instead of taking 28 days, the keratinocytes can make it to the surface in 7 days or 5 days. I mean, they can do it really quick. And as they do that, they start building up because they don't slough off fast enough, and you wind up with these plaques of roughened skin, scale. They can be quite severe and cover a large part of your body. They can be very discreet, only on certain surfaces or on the back of your neck or something like that. But psoriasis, I don't know what % of the population has psoriasis, but I'd say probably at least 5 or 10% of the population has psoriasis. So very common disorder. Scleroderma, on the other hand, is a rare disorder that's really a nasty disease. It involves abnormal collagen synthesis and degradation. And what happens here is the collagen becomes hardened, and these people, it says down here somewhere that it turns people to stone. That's exactly what happens. If you look at these fingers here, there are no wrinkle lines. They're shiny, they're waxy, they're taut, they can't bend their fingers. Scleroderma is a really horrible disease. It also involves not only the skin, but also the linings like the pleura and the pericardia and things like that. So these people usually die a very horrible, slow progressive death. There are different degrees of scleroderma. The different types of scleroderma determine the progressiveness, but it's never good. It's never good. Scleroderma is also usually related to Raynaud's phenomenon. Everybody knows what that is. It's a vascular disorder where if you get out into the cold, the blood vessels on your fingers constrict, and your fingers turn blue, painful, and it can be an aggravating condition. Raynaud's phenomenon with scleroderma is never good. Okay? I think maybe I mentioned before, I have known a few people with scleroderma. One of them was a medical student when I was at OU, and she had it really bad. Because of the degree of Raynaud's phenomenon, she had lost most of her fingers, had to be amputated because of the gangrene. But she completed medical school, started her radiology residency, and unfortunately died when she was an intern So it is a horrible, horrible disease. But she was such a wonderful person, that was what made it all the more tragic.
How quickly does it progress? Like, what's the?
Again, it's very variable. In some people, it can be a matter of years and you're dead. In some people, they can live 10, 15 years. It's never good. Now, they treat it now, the treatments now for it are much better than they used to be. Now they're using all sorts of biologic agents, the immunoglobulins and things like that to attack the disease rather than just treat the symptoms like it used to be.
Is it caused by something or?
It's a genetic condition, yeah. Well, I say genetic condition, it may be a spontaneous mutation, but it's a,
Is it kind of like RA where they're not sure they use biologics in rheumatoid arthritis?
it's considered a connective tissue disease along with RA, Sjogren's disease and things like that. Okay. Now, the deepest layer we talked about was the deep fascia. Again, the outermost covering of the muscles. This is a very thin layer. It's probably less than a millimeter. It's almost like a sheet of paper. However, because of the orientation of fibers in these deep fascia, it is tough. It is hard. You cannot rip it. You can, if I take and open today in lab, when you start removing the skin of the back, you can rip the subcutaneous layer. You can't rip the deep fascia. It's too tough. Okay? Here's a thing you're going to see a lot of. This is a decubitus. If you can't get oriented here, here's this guy's sacrum, and there's his legs going that way. Here's this guy's sacrum, and his legs going that way. A decubitus is a pressure ulcer for people who don't move. Whether or not they be in a nursing home or quadriplegic, paraplegic, and they're sitting in a wheelchair all day long, it's a pressure ulcer. If you put pressure on a body part, it's going to become over time hypoxic, and you're going to start having skin breakdown. Stage 1 is mostly just a little erythematous, which means red erythematous, like you see here. Stage 2 and 3, you start getting deeper penetration into the tissues. Stage 4 is you're all the way down to the bone. That thing right there is the issue of tuberosity, which is the bony part you're sitting on right now. This is obviously somebody sitting in a wheelchair all day long, where the cubidi have gone down to the issue of tuberosities and to the sacrum. When you get to stage 3 and stage 4, the only way to close these things up is by skin grafting, which is not usually a good thing because they're immobile and they're poor tissue to start with.
You said it was caused by hypoxia?
No, if you're sitting on something, it's the pressure that's causing chronic decrease in blood flow to an area. Over time, the skin starts to break down. It's not like you're going to have gangrene in the butt, like from sitting through anatomy. But if you're in a wheelchair and that's all you do from the time you wake up until 11 o'clock at night, this is what you're going to look like. And I've seen these. There was a guy from Blackwell, one of the physicians up there. One of the physicians, I can't remember which one. There was a young guy, a teenager, came in. He'd been in some kind of accident or something. Came in on a spine board and a seat collar. He took the seat collar off, and the guy winds up with a cervical spine injury. Now he's a quadriplegic, and he didn't care. And now he was 19 years old, and he shows up, and this is a clinical tip for you. He sits in his wheelchair all day long. He comes in, and that's what his backside looks like right there. That's exactly what his backside looks like. You can sit there and look at his sacrum, and you can look at his issue of tuberosities. You can touch the bone. My mistake with him was he has an indwelling suprapubic catheter. So, because you can't pee, obviously, if you're quadriplegic. And over time, because he didn't take care of himself, the pressure of that catheter essentially just eroded the bottom of his penis. So he had a channel there where his urethra should be, and the catheter came out kind of down the bottom there. Well, he was uroseptic, he had, his urine was just infected, and I made the mistake of removing the catheter. Well, you know, something like that, you gotta remove the infecting thing. Don't ever remove a catheter from a quadriplegic, regardless of the condition, because you're never gonna get it back in. So it took me the better part of the night to finally hit the right little channel to get that catheter back in this kid. I'm sure he's dead by now.
Does it become like a blackening because of the ischemia? Or?
Yeah, it's gangrenous, it's dead, it's dead, oh, it's dead, yeah, it's dead. This is right here, that's just dead tissue. That's why you've got a skin grafting. You can't heal that. You can't send that to wound care and get it healed over time. That has to be excised and grafted.
What does a wound vac do when it's in place?
I'm sorry?
What does a wound vac do when it's in place?
A wound vac?
Yeah.
A wound vac would be like if you had chest surgery and you had drainage. A wound vac is a little device that maintains suction and it will help suck out pus and other things like that. A wound vac is not something you use on a superficial wound like this. Okay? There's a whole science to wound care, and they can really work magic on nasty wounds. But the cadavers we had here in December that we were working on, the guy had essentially one of those on his heel. So he had a good stage 3 decubitus on his heel. I didn't pay attention to the cadavers over there if they had any decubiti. All right. A couple more slides and we'll take a break here. Langer's lines, if you look at the collagen here, the collagen, or the strength of the skin, is not just arranged haphazardly through the skin. It's in predominantly parallel lines, and that gives the tissue strength because of that. And the lines are perpendicular to the stress, and so that's good because that gives you more strength. As you can see here, these fibers are tending to be running that way. If you look at your collagen, the way it's distributed in your skin, it's like that, along Langer's lines. So if you're going to make an incision in something, you would want to make that incision parallel to Langer's lines. You want to try to avoid cutting across Langer's lines. You see what I mean? So if you've got, if Langer's lines are predominantly this way, if you make your incision like that, it will be much more cosmetically pleasing and strong once it heals than if you were to make it like that. So you want to try to always, when you have an elective skin removal thing that you're getting ready to do, you always go parallel to Langer's lines. If you don't, and they come back with this hugely ugly scar, then call an attorney, because you could be sued. All right? So having some knowledge of Langer's lines is crucial. Now, you can determine Langer's lines on yourself. If you just take your skin and just lightly put pressure on it, you'll see that the Langer's lines become apparent, like this. All right? So what you want to do is make your incision parallel to Langer's lines. Now, if you're doing a punch biopsy, which is what this thing is right here, if we've got some lesion and we're going to punch, it's just a round circle. It's sharp. You just stick it into the skin, down to the hub there, pull it out, and pull the thing up and cut it free from the bottom, and now you've got your lesion right there. But if I take a round thing and stick it in your skin and pull it out, what is the hole going to look like? is gonna be a round hole. If you put a suture in a round hole, what happens to the edges is they pucker. That's not good. So what you wanna do is take your fingers, put them on either side of the lesion, and push Langer's lines perpendicular. Put force on Langer's lines perpendicular to their orientation. You do the punch biopsy. When you let go of your fingers, you wind up with an ellipse. Now you can put a stitch in the middle of that, and there's no pucker. Okay? I was, kind of a funny story, it was on this leg. It was on this leg. I can't remember which leg it was on. This was back in, about 2012. I had a little lesion on my leg. It was a freaking freckle. My wife was absolutely convinced it was melanoma. So I go over to OU dermatology, because when I was at OU, go over to OU dermatology clinic, and the medical student was there with the resident said, "Can the medical student take it off?" I said, "Sure." So she takes a punch, and I see that she's getting ready to just punch it without doing this, so I know she's going to be left with a hole, but, you know, this is a teaching moment. So she stuck me on the screen and cut it out, and sure enough, there was a perfect hole right there in the top of my thigh, right here in the middle of my thigh. And so when she put that stitch in there, there was a pucker on the side, and I said, "Let me give you some advice." And I told her about this Langer's lines thing. The problem was she put a 5-0 stitch in there. The 5-0 means the thickness of the string, and 5-0 is thin. It's really thin. And I was looking at her putting that in there, thinking, that ain't gonna hold. So she put it in there, and so I go walking back to the program, and all of a sudden, when I had my scrubs on, when I would put this foot down, it would go squish, squish. And I looked down, and the whole front of my scrubs was just bloody, because there was a perfect hole, and I was just bleeding right out that hole. So, moral of the story, don't forget this, and use an appropriate size suture material. Yes, ma'am.
For example, I had a knee surgery, and I see that the Langer's lines go, a certain direction, but they cut the perpendicular way. What about?
Well, there are some times where you can't avoid going across Langer's lines. There are some times. Now, most of the times you're going to be suturing somebody due to a traumatic laceration, and that pays no attention to Langer's lines. But there you go. Go ahead and take a break, and then we'll come back.
We don't let any of those bed sores on our belly.
I already done it, so.
Like, I have clavicle and one on my ear. I'm sure you can't see the one on your ear. Or clavicle, like, clavicle's got a really good but like, they're really but they were, I think,